You know, there's a reason why a lot of the screening and preventable strategies that are embedded in our country target Aboriginal people who are aged 50 and over.
Welcome to Series 3 of the Future Health Podcast, a podcast on the way we work, the work we do, and how technology will influence the future of work in New South Wales health and the healthcare industry. We have an incredible lineup of guests this series, and we look forward to sharing it with you soon. Feel free to like, share, and subscribe so you don't miss a thing. Hello everyone, our guest today is Belinda Field, CEO of Yerin Aboriginal Health Services and board member of Central Coast Local Health District. Belinda has extensive leadership career in health and within Aboriginal communities, providing strategic direction and managing operations for several associations and services. I'm so looking forward to learning more about this within the context of Future of Work. Welcome, Belinda, and thank you so much for being on this podcast with us today. I was hoping you would be able to introduce yourself to our listeners and give us a bit of background from your point of view.
Thank you. Good morning, Sharisha. And firstly, I'd like to acknowledge that I'm coming to you from Duncan country on the beautiful Central Coast and pay my respects to my elders past and present. And yes, I am a proud Wiradjuri woman. However, I've grown up on Duncan country most of my life. I am the current Chief Executive of Yerin, Eleanor, Duncan Aboriginal Health Services, and I do sit on the board of the Central Coast Local Health District, have done since 2017. And I might mention that I've just celebrated 6 years with Yerin, Eleanor, Duncan on the 10th of August. So pretty big achievement for me, given my background is actually in child protection education. So I spent 10 years with the Department of Communities and Justice, formerly known as FACS, and also in the classroom in a local primary school for 4 years. So yes, very passionate about Aboriginal health, and I might just do a bit of a shout out to the namesake Eleanor Duncan. So Eleanor Duncan is in fact the name of our medical centre, and it was named after a remarkable woman who sadly we lost at 48 years of age due to a very preventable disease. So Aboriginal health is very close to my heart, and ensuring that we don't lose our mob before they turn 50.
Yeah. Let's talk about the big disruptor, the elephant in the room, COVID. COVID has fundamentally changed the world. So what has been the experience, if you can share that, from an Aboriginal community's point of view? Like, how has COVID changed the way services are delivered to those Aboriginal communities? What impact has it had, and what can we learn really from the way we've dealt with it?
Okay, so I'll answer that in a couple of segments. I think I'd like to acknowledge that Aboriginal communities have been in a pandemic since 1788.
True.
to be brutally honest, and I think that, you know, we've got a beautiful elder in our community, Aunt Nola, who's in her 90s, and that's, you know, by virtue of Aboriginality, that's in this country, that's very rare. And, you know, as the chief executive, that very quickly had to execute some plans and some strategies that I've never experienced in my life. I haven't been through a pandemic as such. And I said to her, Aunt, you know, this is tricky. How do I navigate this? She said, oh, girl. She said, we've been through swine flu. We've been through, you know, them white fellas putting smallpox in our blankets. We'll be right. We will survive. And I thought, you know what, she and that's her. She's a true optimist, absolutely. But she said to me that it's about communication and making sure that we stick together. They were the two key messages, and that's exactly what we did, Sharisha. We as a community come together last year. You know, we sent out messaging through our social media platforms. We did mail outs. We had our Aboriginal health staff do door knocks. And as you can appreciate, the Central Coast isn't a condensed, discrete community. It's a very spread out community. It's equivalent to the size of ACT. So one AMS to try and cover that geographical area to make sure that, you know, in those early days, particularly targeting our elders and those with chronic disease. And of course, the Delta strain decides to knock on the door a year later, and we had to ramp up actions. So we responded as we normally would. We're a very resilient people where we have our own solutions. You put Aboriginal health in Aboriginal hands, we will stop our mob from going into hospital. We will increase, wellness, both spiritually, culturally, health. Yes, we've got a lot of catching up to do. And I think what it's also demonstrated during the pandemic, that unified voice, particularly through AH and MRC, they really had to knock it up a gear as our peak agency, agitating Commonwealth and state government. So it's actually put us on the map, if I must say. It's highlighted that the government can turn on and off levers when we're constantly told, oh, there's no funding for Aboriginal health. Oh, no, the bucket's dry. No, I would challenge that and say, well, where's the universal bucket? Because you get it right for Aboriginal people, you will get it right for everybody. And I think that I'm hoping, demonstrating through this pandemic, we as a region were one of the first to develop up and refine and implement our own pandemic response, which we openly shared with the local health district, the public health unit, Nanyara Aboriginal Health Unit, and it just highlighted again just how resourceful we are with no resources.
Yeah, and it's interesting because you talk about, putting Aboriginal health in Aboriginal people's hands. So how responsive was the community and did you have to do things slightly differently? Like, have you learnt new things in the way you engage? It sounds a bit strange to say, but with your own community, I suppose, to kind of encourage them to be safe or, step forward and go get tested or, make sure they follow public health orders. Was there things you had to do differently? And I'll link it back because I was thinking when you talked about engaging with the Commonwealth, we have sort of fundamentally changed or there's a perception that we need to change the way we work in order to deal with new challenges. So it would be really interesting to hear your thoughts from your point of view about, did you do things differently? Was there better engagement from the community?
I don't think we did anything different necessarily, to be honest. I think because one thing about Aboriginal communities is they engage really well. And I'm not saying that's with everybody. I mean, everybody's individual. Some of the Aboriginal community were okay with, accessing their regular GPs or, but we have a vast majority of vulnerable people in our community. We've got on the Central Coast one of the highest rates of homelessness, one of the highest rates of child protection, and one of the highest rates of domestic and family violence. So whilst we didn't do anything differently, it forced local community to really step up and call things out a little bit. I think that we relied more on saying to community and really empowering community to protect each other, which, we typically do, but we just had to amplify it. And what we learnt, not that we did it differently, but I think it added another layer of vulnerability to mob that aren't necessarily vulnerable. And so it was more reaching out and us re-engaging or going, hey, we're here. It's okay. There's no shame in saying I'm doing it a little bit tough. And I think that, there is a lot of, we're seeing a lot of increase in mental health unwellness. So again, very quickly, we're able to broker some really beautiful relationships with the likes of Oz Harvest, where we're making sure that food security and good nutritious food is getting out to our community and the most vulnerable members of our community. We wanted them to stay home, but understand that connection for everybody is really, really important, but it's fundamental to who we are as a people. And we're seeing that in the western parts of New South Wales where, we're seeing Dubbo and areas like that where households have up to, 10 mob living together. We have that on the Central Coast. How do we isolate someone who potentially has COVID when, they've got extended family or immediate family living with them, and it's a 3-bedroom home, 1 toilet, 1 bathroom. They're the real issues that weren't necessarily considered in the original rollout of the pandemic. That as an Aboriginal community, we had to say, well, how are we going to do, we called it an extraction. It was like, Black Hawk Down. If one of our mob become unwell, how are we going to get in there and get them safe? And we actually did a mock run. We had put a pandemic response team together, which I was very proud of. The Academy Award actually went to one of my nurses who was in the know, but the other members of the team had no idea that it was a fake one. So the adrenaline was running, but it was,
wow.
Yeah. The reality is that that's potentially what we would have had to have done. Thankfully, the Central Coast has had relatively low transmission through the Aboriginal community, and I think that that's because of the joint efforts of what we've been able to do.
I was thinking, seeing as we're talking about the future of work, and if we talk a little bit about technology, was there any interesting or new technologies or existing technologies that you use to support that response and the way you provided services and care to the community? Because I think going into the future, those are the sort of things that we obviously want to piggyback on and use those opportunities to build into our learnings about the future of health and technology, I suppose. Yeah.
Well, we quickly moved to telehealth. And going back to your early question when we were talking about doing things differently, part of our funding to the Commonwealth is the Indigenous Australians Health program, and it's built on the back of the number of 715s, which is a Medicare billing item number essentially for Aboriginal and Torres Strait Islander people in this country. And so part of that is it's a preventative health measure. So I understand absolutely, it needs to be done. And we struggle a little bit in getting high numbers of 715s done. And it's purely on the basis that we have a rural GP shortage. Aboriginal health isn't for the faint-hearted. You absolutely have to be very passionate. So what the pandemic taught us very quickly through telehealth is that some of our elders in particular that no longer have a license or, are a little bit, accessing our centre at Wong sometimes is tricky. Like I said, we're a huge geographical area. If you live at the very northern end, it can take up to, 40 minutes to get into Wong. If you live on the southern end, sometimes 50 minutes depending. We're on a train line, but if you're unwell or you have chronic disease, riding a train is not necessarily the best thing. So what we did with our nurses is they were conducting the 715s via telehealth. And so we've seen an absolute increase. And we actually had feedback from some of our elders, older sort of 75 and over, saying, wow, this has been really good. I've really enjoyed having a yarn with you today. It takes away from that confrontation of having to go into AMS waiting area, seeing other people there that are unwell. And it just it was in the comfort of their home. It brought a bit of safety. And of course, if anything was flagged, one of our Aboriginal health workers would jump in the car, mask up, put their PPE on, and out they'd go. So I guess, we learnt lessons from that, and we've continued that process.
Right, yeah, because I was going to say you saw an increase in uptake with the telehealth, so that's something that you would continue on. So I guess, is that something that New South Wales Health should continue to focus on in terms of virtual care? And because there's a lot of work being done at the moment around, everyone's talking about it's the new big buzzword, virtual care, and, we provide virtual care. How do you think we balance the provision of telehealth while still maintaining that patient-to-patient interaction, particularly, for, say, remoter Aboriginal communities that don't have access to technology? I think I guess my question is equity for people that do have access to technology versus the people that can't afford it.
And I think the key here is balance. I think that it would be really remiss of the government to replace and rely solely on virtual health. and for a number of reasons. So, wound care, blood pressure, BCLs, you can't do that virtually. The other thing that bothers me with going to virtual health, and something that really concerned me during the pandemic, is we've got this beautiful interdisciplinary model at our Aboriginal community controlled health centre, which I believe other, New South Wales could also learn from. The GPs and Aboriginal health workers develop up a beautiful relationship around continuity of care. And so we get to know our community, even our reception staff from the first point of contact. They'll know if something's going on. And like I said, we're a community that sadly has a high proportion of family violence, child protection. If we go to virtual health, where are the eyes on the kids? Where are the eyes on, victims of violence? How do we manage assessing whether somebody is just a little bit sad today, or he's acutely depressed? So I think that there is an opportunity for us to use virtual health, but I don't think it should replace. And I'm not saying that's certainly not that isn't what's been communicated, but I think virtual health, and I'm going to be bold, is okay for people that aren't necessarily vulnerable or don't have the complex health issues that we do.
Yeah, so the future of work, I suppose, is also then linked right back to education and how our clinicians are trained in the future from an Aboriginal health perspective, because, absolutely I'm sort of listening to the things you're saying about, only people who work in Aboriginal health will understand the nuances. What do you think in terms of if you could provide advice around what should education look like in the future for clinicians? Obviously, they're not going to be not everyone's going to be specialised in Aboriginal health, but for, say, an Aboriginal person who walks into an emergency department, what are the things that should be included in future education so that clinicians can understand that when they are, when an Aboriginal a person is a patient, that they need to think a little bit differently,
Well, I'd like to strip it back another layer. I'd like to see more Aboriginal students alongside non-Aboriginal students in studying medicine, studying nursing, studying, specialists, and because that's where you actually have some great learnings. And we know that education for our people is severely disrupted. I mean, it's a part of the Close the Gap target. So it's kind of like the chicken or the egg, and there's this follow-on ripple effect. So we don't have a lot of Aboriginal GPs. We don't have, a cast of thousands of Aboriginal renal specialists or cancer specialists. And so I think what we need to do is really do some early education right back here, targeting our, young people in high schools, encourage them, support them, stop having these low-lying expectations where, when you finish school or you can become a barista, and no disrespect, but why is it that, Sharisha, I'd imagine around your kitchen table growing up, your discussions weren't about just surviving and putting food on the table. I hope it wasn't for the majority, but for our people, it's like, how are we going to pay rent this week? Gosh, I hope we don't get evicted. How do these young people stay connected to school when they're surviving poverty? And, the broader community, that doesn't happen in our country. That happens in third world or developing countries. Well, I'm here to tell you it's happening in your backyard. And then our mob get penalised or criminalised for being poor. So I know I've gone a bit deep there, but I think that it's not our job. It's not our job to educate clinicians. It's their job to seek the information. If they don't know something about the anatomy of a human and that's a part of their medical degree, don't they go and study that until they know it? Well, I encourage them. If you don't know about Aboriginal health, you don't know about Aboriginal people, go and learn. It's not my job as an Aboriginal woman, First Nations person of this country to teach everybody else what it is for me and what it's like in this country. It's your job.
Yeah, yeah. No, I agree with that. But I guess I was thinking more around when they are at university and doing their, undergraduate study, or if they're at
Sure.
TAFE.
Yep.
Is it something that should be included? Because we talk about clinical skills, and then, there's a push for sort of soft skills, and you're going to have to understand empathy and emotional intelligence. But obviously a core part of what may be missing may be around Aboriginal health, and whether that's something that should be included as part of curriculum.
Absolutely.
What do you think?
Yeah, absolutely. Wholeheartedly agree with you. And what I'd like to see is some of those mandatory components resource Aboriginal medical services, so that each of those students, postgrad, undergrad, whatever, come through and actually have to do a placement in an Aboriginal community setting. Rural, remote, regional. There's this notion, if I go rural, I'll learn everything that there is to be Aboriginal. Well, I can tell you again, East Coast is completely different. Even on the Central Coast, like I said, with the size of the ACT, we've got, I call it the diamond. We've got the northern, east, west and southern end of the coast, and there's Aboriginal community within Aboriginal community. So how you might manage mob on the northern end might be not how you engage with mob down at your minor. You also, we're on the lands of the Duncan young people, but we're from many nations. We've got lots and lots of Aboriginal people on the Central Coast from right across Australia, right across New South Wales. We also have a high proportion, between 20 and 30% of our young people are members of the Stolen Gen. So I would encourage institutions and New South Wales to Health to make those placements mandatory, even secondments. We've talked about that from time to time here on the Central Coast, but again, it comes back to resourcing. And all the heavy lifting is typically left up to the AMS, who's the least resourced. So there's some thoughts and considerations I think that New South Wales Health could do in practical terms.
Yeah. It's interesting when you talk about vulnerable people or picking up some of those signs, I guess, and that only comes from experience of human clinicians, and possibly back to what you were talking about, because I was going to say about bias, and whether we talk a little bit about artificial intelligence and things, but bias that's in a machine versus a human being, or say an Aboriginal healthcare worker who is not going to have the bias about a particular group of people necessarily when they're providing care.
Shirisha, I think the other thing that I'd like to note there about future health and virtual health and artificial intelligence, I mean, a lot of the assessment tools, mental health assessment tools, health assessment tools that are used in Western culture aren't designed for Aboriginal people. That's why they had to create a 715 health check, because there are particular questions you'll ask an Aboriginal person that you wouldn't necessarily ask a non-Aboriginal person. And thankfully, we've got a suite of GPs that work at Yerin, Eleanor, Duncan, that have openly said, unless you work in Aboriginal health and you actually understand the differences, even biologically, through the evolution of humans, the impact of sugars and different foods that are introduced into Aboriginal culture. The east coast of Australia got absolutely hammered by the colonist, but yet we're still evolving, hence why we've got the highest incidences of diabetes. Our bodies aren't constructed to manage that level of yuckiness. We still see higher incidences of diabetes and renal failure in our rural and remote communities, but a lot of those communities, where they can, still eat traditional foods. So there's this notion again that one size fits all, but really unpacking the layers of that impact of Western culture. Right across the spectrum of a human, right from head to toe, psychologically, physiologically.
So I'm interested to hear your thoughts on the current challenges and opportunities that you've seen in the health sector for Aboriginal participation, and perhaps maybe give us a bit your views on what can New South Wales Health do to improve Aboriginal health outcomes?
Look, I think, and again, primarily on the front line for the last 6 years in health, what I've really noticed is the unconscious bias and racism that exists within the structures. Now, I don't believe in my heart that people are naturally or deliberately racist. Of course, there are people out there that have got prejudice. But I think it's this unconscious bias. They don't even know that they don't know. And so that filters into our structures where Aboriginal people are viewed as a subset of humanity. And you might think, oh, that's a bit radical, but I've experienced it firsthand as a consumer, as a patient, supporting my Aboriginal community access services or lack of access to services, or they're placed at the bottom of a waiting list, or they're left to wait. So there's a little bit of work to be done there, and I think that we need to promote and edify that we've got one of the strongest, richest cultures in the world. And why this country doesn't embrace that will continue to baffle me. Let's celebrate it, let's share it. And so if we get a better understanding of colonisation and its impacts, a lot of these preventable diseases are due to introduce foods and lifestyles that we traditionally were never accustomed to. So it wasn't a part of our journey and our living. So now we're seeing the impacts of that. Like I said earlier, closing the gap. There's a reason why a lot of the screening and preventable strategies that are embedded in our country target Aboriginal people who are aged 50 and over. I'm probably 7 years shy of that, and I think that that's a stark reality that I'm sick of going to funerals of people that should be living into their 90s. And again, it's because I believe some of the barriers is that Aboriginal health is a bolt-on instead of embedding it into the very core of what we do in New South Wales. It'll be forever sitting outside of the remit for health more generally.
Yeah, it's interesting you should say that, and I mean, given this is a Future of Work podcast, it's a good segue into what you were talking about bias and unconscious bias being sometimes a little bit more difficult to tackle. What does that mean for Aboriginal people, and how do you think New South Wales Health could tackle some of those unconscious biases?
Interesting. I think that Aboriginal communities, whilst are used to it, are sick of it, that we've since 1788 had change and things thrust upon us. We're a very, very adaptable culture, very ability to pivot really quickly. And of course, it relies on key leaders bringing Aboriginal communities together. And I think that some of the solutions to going into the future, whether it be via technology or whatever, is listen to local communities. I think that there's also this notion that one size fits all, and that, well, if you talk to one Aboriginal person, well, that'll solve it for everybody. And that's certainly not the case. If you talk to one man, doesn't mean that you're going to resolve everything for all mankind. And I think that we need to rip the Band-Aid off. We need to be honest and courageous. I think if New South Wales Health are genuine in wanting to not just close the gap, but exceed the gap, it's about looking at, okay, how do we tackle unconscious bias? It's through education. On the Central Coast, we've got a local, it's through local decision-making empowered communities, which is a national and state government initiative, which I won't go into right now, but it is where 7 of the 8 Aboriginal organisations opt into a regional governance structure. And so we've been very clear on a local level to address and meet the needs of 15,000 Aboriginal people, that our local health district really needs to be embedded in culture and really understand the local landscape. So get on country. It is an education like no other. There's an online platform, and with all due respect, 2 hours, to understand a fluid, living, breathing culture is actually insulting. The Central Coast, we've got beautiful knowledge holders, traditional owners, Auntie Bronwyn Chambers, Uncle Gavi Duncan, who can take you through the paces, can show you medicinal plants that still exist on country. Warren, one of our most beautiful Aboriginal sites that is full of rich history and knowledge that you won't get online in a 2-hour course. So that's where we need to start to move into the future. I've been fortunate to be able to include a couple of our board members from the Central Coast Local Health District. Changed their views. They were safely able to ask some of those, those awkward questions like, why do Aboriginal people need an AMS? Why do Aboriginal people have targeted programs? To the average folk, they think that it's a privilege. It's actually not. It's sadly so that we can catch up in life expectancy.
I think we might be coming close to time, but I just wanted to ask you one final question. So do you have any future advice or thoughts around what you think the future of work and, the future will bring for Aboriginal people? And what can we all do together to prepare for that and ensure that their voice is included in the change?
Yeah, sure. I think my advice would be talk to your local leaders. Talk to the local Aboriginal community, get to know your local Aboriginal community. I think that I'd like to see genuine on-country experiences where, it's no mean feat. I think the local health district, Central Coast Local Health District, employs over 7,000 people. But how do you start change? Piece at a time, just start it. We've got that local knowledge, do some cultural immersion, on-country experiences, have those fearless and frank discussions, unpack your unconscious bias, change what you don't know, challenge yourself, we're talking about people who are highly intelligent. Again, baffles me that there's this notion, you can't really ask those questions. Well, you can. It's about education. Make the institutions culturally safe so that Aboriginal people are heard, not just consulted, but embedded in everything that we do. I think that's probably my very broad stroke advice.
No, that's great. Thank you so much, Belinda. And thank you so much for your time and participating in this podcast. I hope you've not been too put on the spot, and I hope you've had a good time. I've certainly learned a lot from you, and I look forward to continuing to engage in the future.
No worries. Thank you, Shirisha. Thank you.
So that's all we have time for this episode. Thanks for joining me on the show. If you enjoyed the podcast, make sure to like, share and subscribe on whatever platform you're on right now.